Welcome all to the class. We begin with our today's session on NHS Cervical Screening Program. Okay. We begin with our quote, Master MRCOG with concept-oriented clarity. So, this particular topic is going to be very, very important from your MRCOG Part 2 point of view. In Part 3 also, there will be session on either you need to explain to the role player regarding colposcopic examination, or you need to disclose the reports and all. So Part 2 as well as Part 3 point of view, this particular topic is going to be very, very important. Okay. And mainly the EMQs will be asked. Most of the EMQs will be asking you about the next step. They'll give you the scenario in which they will be giving the report that the cervical screening is performed, HRHPV is positive. This is what is her cytology report, and what will be the next step. They may give the colposcopic findings also, and maybe treatment follow-up they can ask you. Okay, so we begin with our NHS cervical screening program. Objective is to reduce the incidence and mortality of cervical cancer via systematic population-based screening for individuals aged 24.5 to 64 years who have cervix. Okay, so what is the age of screening? Generally, it begins at 25 years of age, but 6 months prior to the 25th birthday, they will receive the notification regarding the cervical screening, which is due. So the first screening starts at 25. They receive the notification 6 months prior. Okay, so 24.5 to 64 years who have the cervix, these are the individuals who are screened. And what is the method which is used? Okay, here they use primary HPV screening. We know traditionally the cytology was used, but now what is preferred is a primary HPV screening, because HPV is the most important etiology for carcinoma of cervix. Okay, so HPV screening is more sensitive than cytology in detecting pre-invasive disease. And what is the advantage? It detects both adenocarcinomas and squamous cell carcinomas, then enables longer screening intervals due to high negative predictive value, and effective in HPV vaccinated individuals also. So when you sometimes they can ask you one about the age of screening. So the first invitation will start at 24.5. Okay, screening begins at 25. Okay, and when does it end? That we'll see in the next and subsequent slides. Okay, and sometimes from the biostatistics point of view also, they can ask you the question that HRHPV screening is highly sensitive, highly specific, less sensitive, less specific, high predictive value, high negative predictive value, high positive predictive value. What exactly are, it may be a combination of this. So it is highly sensitive test. HRHPV is highly sensitive. It has got high negative predictive value. However, limitation is that it has got a lower specificity. Okay, so highly sensitive, high negative predictive value, and low specificity. Okay, please remember this. And that is what is the limitation, lower specificity. And because of this, you need a reflex triage by cytology. Okay, what do we mean by low specificity? That means your report is HRHPV positive. Once you get that particular report, it doesn't mean that there is a pathology in the cervix. It means that there is a viral infection. Okay, but for pathology to happen, which can be detected either on biopsy or colposcopy, you need to have the such kind of findings. So only presence of HRHPV is not sufficient. Okay, so when you have the cytology with you, the specificity will increase. Otherwise, only HRHPV will have lower specificity. Okay, is that clear to you? Is it clear? Yeah.
Yes.
So implementation, now it is nationally adopted as a primary screening along with the cytology as a triage. Okay. Nowadays, even there are certain future developments, like UK National Screening Committee recommends extending the screening interval from 3 to 5 years for the ages between 24.5 to 49 with HRHPV negative results. So if the lady's report is negative between this year, that is below 50, if her report is HRHPV is negative, then it is proposed, it is not yet started, but proposed that the screening interval will be increased. And that is one of the advantage, because the logistics will be saved. Okay, so that is one of the advantage, but that is a future development. and it will be implemented once primary HPV screening is fully integrated. Okay, so this is what is the screening frequency between 24.5 to 49 years. Every 3 years, the screening is recommended. There is evidence from UK screening audit, and from 50 to 64, every 5 years it is recommended, because after the age of 50, there is a age-based reduced risk of HRHP. Okay, and after the age of 65 or at the age of 65, this screening is ceased provided the screening criteria are met. That means all her previous reports are normal unless she is under follow-up for any other abnormality. Okay, so the screening is from 24.5 to 64. The frequency is up to 49 years every 3 years. After the 50 years up to 64 years, it is every 5 years. Okay, and it will cease at 65 years provided the criteria are met, unless she is under the follow-up for abnormalities. Okay, suppose if previous smear is abnormal, then she will have the follow-up even after the age of 65. So that is what it means. Okay, now what is the starting age? Starting first invitation will be sent at 24.5 years. Younger individuals. Now, what about less than 25 years? They are not routinely screened under the program. Okay, less than 25 years, not screened under the program. But if there are symptoms, they should consult the GP or gum clinic, and then they will be screened. But otherwise, routine screening is not under the program. Okay. Now, what is the finishing age? Routine screening aims at between 60 to 64 years of age, if criteria for automatic ceasing are met. Okay, that means if her smear at 60 is negative, next will land up at 65. So she does not require the next smear. Okay, but at 59, if it is negative, next will come at 64. Okay, and if it is normal, she will not require further screening. Okay, so the screening ends between 60 and 64 years, provided she meets the cessation criteria. Individuals with prior abnormalities or HRHPV positivity will continue follow. Okay, so those who have positive report, okay, they will not fulfill the criteria for cessation of the screening, so they will be under the follow-up. Okay, and it does not cease due to age if still HRHP is positive or under non-routine recall. Okay, so if there is a non-routine recall means they are under treatment and the follow-up is going on, so that particular case, the follow-up will not end. Okay, so management after HRHPV positive and cytology negative results. If the colposcopy is negative, there is no CIN, she will be discharged to recall after 3 years. Okay, colposcope clinic must inform the call recall service of the next due date. Now, when can she withdraw from the screening? Yes. Okay, cessation from the colposcopy if there is a pelvic radiotherapy which is given, or if there is no cervix, then the colposcopy, there will be cessation from the colposcopy. And patient can withdraw herself from this particular screening, and individuals may opt out of NHS screening program as per the UK government guidance. Okay, now let's see this frequency of the screening and screening method, etc. So between 24.5 to 49 years, every 3 years she will undergo the screening, and the screening method is primary HRHPV positive, along with cytology is used as a triage, and this, it is recommended in future that screening interval may be extended to 5 years in the future. Okay, so currently it is 3 years between this particular age. After the age of 50, the screening interval will become 5 years, and the method will remain same. That is primary HRHPV positive and along with the cytology as a triage. Okay, and after the age of 65 years, there will be cessation of the screening, but the screening will continue if there is a prior abnormal results. Okay, this all we have seen. Now let's discuss about the cancer waiting times and the referral policy. This is going to be one of the important, because in EMQs you will have various options and a lot of confusion will be there with respect to the waiting time. Okay, so you should select the appropriate waiting time in the options. Okay, now when your cytology is showing there is a suspicion of invasion or high-grade dyskaryosis, that is either moderate or severe dyskaryosis, or there is a glandular neoplasia, or you see a borderline endocervical cells. So whenever there is a glandular abnormality, or there is a squamous but high grade or moderate dyskaryosis, that is going to be more worrisome. So these patients should be referred within 2-week wait referral pathway. There are two pathways. One is a 2-week wait pathway and another is a 18-week pathway. Okay, so they will follow this 2-week wait pathway, and she should be seen in the colposcopy clinic within 2 weeks. Okay, and this is what is the target. So more than 93% must be seen within 2 weeks. Okay, this is for the audit purpose. When they have the internal quality assurance audit, that particular because audit is also going to be very important from part 2 as well as part 3 point of view. That is why I am covering these particular figures here itself. Okay, these figures may not be important from examination point of view for part 2, but you should know about the audit. Okay, then if your finding is a low grade dyskaryosis or borderline squamous changes, persistent HR-HPV positive with negative cytology, or persistent inadequate samples. Okay, now here what we have, first thing, there are no glandular abnormalities. There is a low grade dyskaryosis, borderline changes, squamous changes. Okay, there is a HR-HPV positive, but the cytology is negative. Okay, so these patients will have 18-week pathway. Okay, and they should be seen within 6 weeks. Okay, and 99% patients should be seen within 6 weeks. Okay, so these are the two pathways, and this is the time within which they should be ideally seen. And individuals with symptoms or suspicious cervix. And the third category is the patient has got some symptoms like discharge, postcoital spotting, etc., etc. So here again we will follow the suspected cancer pathway, which is a less than 2 weeks, and they will be referred urgently to the colposcopy or the gynecologist. Okay, all referred patients should be informed within 28 days whether they do or do not have the cancer. So this is also one of the important quality control guideline, that they should be informed within 28 days. So their workup should be complete, and these are the pathways which are available. Okay, so depending upon the finding, you will select the pathway and will advise accordingly whether she requires follow-up within 2 weeks or whether she should be seen clinic in up to 6 weeks. For up to 6 weeks, you will have low-grade dyskaryosis, borderline squamous changes, persistent HR-HPV with negative cytology, and persistent inadequate samples. Okay. Now, HR-HPV positive and further result. What exactly is to be done? Now, you consider the HR-HPV. Okay, when you do the HR-HPV and there is an inadequate sample, what is to be done? If HR-HPV test is unavailable or cytology is inadequate at screening episode, then you have to repeat the sample within 3 months. Okay, this is also one of the SBA or EMQ they can ask you, that during the screening, the HR-HPV test, the report is unavailable, or the cytology was inadequate. What is the next step? You have to repeat the sample after 3 months. So wait for 3 months, and after the 3 months, you have to repeat it. Okay. The only exception is that if the cytology remains inadequate at 24 months of repeat test, you will refer the patient directly to the colposcopy. So first sample, if it is inadequate, or first HR-HPV it is unavailable, you will repeat it after 3 months. But if sample at 24 months is inadequate, those patients are directly referred to the colposcopy. Okay. Now referral criteria is 2 consecutive results of either HPV unavailable or cytology inadequate in any combination. They are to be referred to the colposcopy. Okay. Is it clear? Is it clear?
Yes,
Okay.
yes.
So if a single sample is inadequate, repeat after 3 months. If the colposcopy, if the cytology is inadequate at 24 months, she directly goes to the colposcopy. Okay, cytology is inadequate at 24 months, she will go directly to the colposcopy. Okay, and 2 consecutive results of either HPV unavailable or cytology inadequate in any combination, she will be referred to colposcopy. Now, if there is a visibly abnormal cervix, what is to be done? Any visual suspicion of malignancy, she will follow 2-week wait referral and for suspected cancer. Okay. Now, for symptomatic individuals, what does the guidelines say? If there is a suspicion of the cervix, suspicion of the cervical cancer, or persistent postcoital bleeding or unexplained discharge, she will be referred to the gynecologist who is experienced in cervical disease. Okay. Then what are the once the common causes such as infection, contraception, etc. they are ruled out, the gynecologist will refer them for symptomatic colposcopy. Okay, and contact bleeding during sampling is not an indication for referral. So if there is a during sampling, if there is a bleeding, that is not an indication for the colposcopy referral. Okay. Now, management after referral for two inadequate or unavailable results. We have just seen that the patient will be referred to colposcopy if there are two inadequate results or HRHPV unavailable. If you get two such kind of reports, she will be referred to the colposcopy. Now, the scenario is that HRHPV is unavailable or inadequate. We are repeating the sample after 3 months with a single case. Okay, but if two consecutive inadequate or unavailable reports, we are referring her to colposcopy. This we have already seen. Now she goes to the colposcopy. The colposcopy report is normal and adequate. Okay, so this HRHPV was inadequate 2 times, so she went for colposcopy. Okay, now colposcopy is normal and adequate. So what is to be done? We will repeat the HPV test after 12 months. Okay, so we have to repeat the HPV at 12 months. If at 12 months HPV is negative, she will come under routine recall. Okay, and remember the word routine recall, because sometimes the option is given that 3-year recall or 5-year recall. Okay, so it is a routine recall because her routine recall depends on the her age, because between 24.5 up to 49 year, it is a routine recall is a 3 years. Okay, after the age of 50, her routine recall will be 5 years. Okay, so here it is a routine recall. Now what if HRHPV is negative on sample, not on special follow-up, she will also come for routine recall. Okay, so you have done the colposcopy. Colposcopy is normal, so you will do the HRHPV again at 12 months. If it is negative, then she will go for routine recall. Okay. Now findings at colposcopy, it may be normal and adequate. So she will have community follow-up in 12 months. And if HPV is negative, she will return to routine recall. This is what we have seen up till now. Now there is inadequate colposcopy. If there is a colposcopy which is inadequate, then we will repeat the screening test and colposcopy in 12 months. Okay. So for two consecutive inadequate samples, she was referred for colposcopy, but the colposcopy was inadequate. So in that particular case, what we have to do, we have to repeat screening test as well as colposcopy in 12 months. If repeat colposcopy is normal and HPV is negative, she will be discharged to the routine recall. Okay, and if the colposcopy is abnormal, then as per the abnormal colposcopy protocol, we will follow her up. That we'll see in the subsequent slide. Is it clear to you? Is it clear?
Yes, sir.
Okay.
Yes, sir.
So can you summarize it in short?
Yes, sir. If the high-risk HPV is unavailable or if there is inadequate cytology, we'll repeat the sample in 3 months.
Correct.
But if two consecutive samples are inadequate or unavailable, if the results are unavailable, then we'll refer them to colposcopy.
Yeah, and further management will be as per the colposcopy. Now we have a colposcopy option. One normal and adequate, another is inadequate, and third is abnormal. So tell me about this now.
Yes, sir. If it is normal and adequate, sir, we'll go ahead with the community follow-up in 12 months. And if the HB is negative, we'll return to the routine recall. If it comes as inadequate, then we'll repeat the screening test as well as the colposcopy in 12 months.
Yeah.
If the repeat colposcopy is normal and again the HB is negative, then we'll again go back to the routine recall.
Correct.
If it comes to abnormal, we'll follow the abnormal protocol.
Okay, and that abnormal site colposcopy protocol, we'll see it may be CIN1, CIN2 or CIN3, etc. That according to the flow chart, we will follow that later. Okay, now you have a situation where HRHPV positive results and there is a negative cytology. So only HRHPV is positive, the cytology is negative. Okay, first what we have seen, HRHPV was inadequate or the cytology was inadequate. Okay, but now second scenario in which HRHPV is positive, but only HRHPV has got a high sensitivity, low specificity. So we have to do cytology, but the cytology is normal. Okay, cytology is more specific. Okay, now what to do? Should we refer those patients for colposcopy? Because if we refer the patient only on HRHPV result with a normal cytology, there will be lot of burden on the colposcopy clinic. Okay, so unless there is a cytological abnormality, either low grade or high grade, you do not refer these patients to the colposcopy. Are you getting it? Is it clear?
Yes, sir.
Yeah. So when you have a initial HRHPV positive, but the cytology is negative, what you will do? You will repeat HPV test in 12 months. Okay. So you will repeat HPV in 12 months. If repeat HPV at 12 months is negative, then she will directly go for the routine recall. Okay. So that means body has taken care of the HPV virus itself. The viral infection is taken care by the body itself. So there is no need for the colposcopy. But if at 12 months the HPV is positive, the cytology is negative, okay, that is at uh, uh, 24 months, okay, so then she will be referred to colposcopy. So what do? You keep her for follow-up of HPV test 12 months. Every 12 months, this she will be for follow-up. And at the end of 24 months, if the HR-HPV is persistently positive, then irrespective of the negative cytology, she will go for colposcopy. Are you getting it? Is it
Excuse
clear?
me, sir. The
Yes.
24 months includes two tests, no, sir. The first test,
Yes.
which was
Yes. Yes.
already
Two
positive, and
tests.
this is
Two
the
tests.
second test.
This is the
Okay.
second test. So first test was HRHP was positive, cytology was negative. So we never wanted, to go that patient to the clinic. So we did a repeat HPV in 12 months. Okay, that repeat HPV was also positive. So again, repeated at 12 months.
12
Okay,
months. Yes.
and at 24 months, HRHPV was positive. Then even if the cytology is negative, okay, that patient will go for colposcopy because there is a
Okay.
body is not clearing that particular virus. You got it?
Yes.
Okay.
Yes, sir.
So, and if there is a TOC pathway, that is test of cure pathway, then she will be immediately referred to the colposcopy. That will see TOC pathway. Okay, but the initial part is clear to you. HRHPV
Yes, sir.
positive, cytology negative. Okay. At the end of 24
Yes.
months, colposcopy. Okay. Now, next situation. HRHPV is positive and abnormal cytology. So this is the third scenario we are looking at. First was inadequate. Second was HRHPV positive, cytology negative. You got it? And this is the third scenario in which HRHPV is positive, but the cytology is abnormal. And all these patients, this abnormal cytology may be low grade or may be high grade also. Okay, that means moderate or severe grade of dyskaryosis. Okay, so these all patients will be referred to colposcopy immediately. Okay, and the weight pathway will depend upon the cytology grade. That also we have seen. Any glandular abnormality within 2 weeks. Okay, moderate to severe dyskaryosis 2 weeks. Okay, uh, this mild one is 6 weeks, I guess. Okay, so benign now. Suppose this in cytology there are benign endometrial cells. So these are to be reported only in HR-HPV positive sample if the patient's age is more than or equal to 45 years. Sometimes this particular report may mention about the benign endometrial cells. So these are to be reported only after the age of 45. Okay, not below the age of 45. If menstrual history is not known, then that has to be commented in the report. So when the cytology report is there, that particular cytology report along with HRHPV positive, if you get benign endometrial cells, then they are to be reported only after the age of 45. And if the menstrual history is not known, then you have to mention that particular thing. And if there is a history of abnormal bleeding or if there are any suspicious findings, she will be referred to the gynecology. So these patients, so when if there is a finding that the report shows benign endometrial cells, you look into the age of the patient, look into the history of the patient with respect to the menstruation. If there is any abnormal bleeding, the next step will be referred to the gynecology. Okay, so she requires gynecological referral for any maybe AUB related management. Okay, so this particular thing you should remember, and the referral standard is more than 93% within 2 weeks of referral for suspected cancer. We have seen the standard is 99% for 6 weeks pathway and or 18 weeks pathway, and 93% for 2 week pathway. Okay, now, if there is abnormal cervix, any visual suspicion of malignancy, urgent referral, that we have already seen. Okay. Now, if the patient is symptomatic, that is the suspicious cervix or persistent postcoital bleeding or unexplained discharge, they will be referred to the gynecologist experienced in cervical disease, and we will rule out common causes of infection, contraception, etc. The gynecologist will refer for symptomatic colposcopy. Okay, that is not under this particular program. That is for symptoms related referral. Okay, then contact bleeding during the sampling is not an indication, that also we have seen. Okay, so this we have already seen. Now coming to the TOC pathway. Okay, treatment, follow-up and test of cure. Okay, so there was a colposcopic abnormality, and further treatment like excision is done, that is LEETZ or LEEP has been performed. Then what will be the cure? What will be the test of cure pathway? The test of cure means you have to repeat the HPV. Okay, so this HPV is repeated at 6 months post treatment. Okay, so cervical sample for HPV is taken at the end of 6 months. If HRHPV is negative, she will be called for recall after 3 years. Remember, this is recall after 3 years. Previously, what we have seen was a recall, a routine recall. Okay, here it is a recall after 3 years. What does this mean? Even if her age is say 50, okay, then her routine recall becomes every 5 years. But if she is under the TOC pathway, her recall will be after 3 years. Okay, not after 5 years. After 5 years will be her routine recall, but under the TOC, her recall will be after 3 years. Okay, if the HRHPV is positive, she will be referred to colposcopy plus reflex cytology. Okay, so there will be multiple options, 8 to 10 options will be there, and you have to select appropriate option. Are you getting it? Is it clear?
Yes, sir. Yes, sir. Yes.
So we'll revise it once again. You have given colposcopy guided treatment. What is the test of cure? Test of cure is HRHPV positive HRHPV test at the end of 6 months. If the HRHPV is negative at the end of 6 months, she will be called for recall after 3 years, not a routine recall. Okay. If at the end of 6 months, that is TOC, you do the TOC, but it is positive, she will be directly referred to the colposcopy along with the cytology, irrespective of cytology, whatever the report, that she will be referred to the colposcopy. And this is for squamous type of changes, not for CGI. CGI follow-up is different. Okay, this is also a question. Most of the time the CGIN is also asked. Okay, so remember the CGIN follow-up is different. CGIN requires 2 tests of cure. Remember this particular sentence, CGIN requires 2 tests of cure. Okay, while non-CGIN only 1 test of cure at 6 months is sufficient. And this is if it is negative, routine recall. If it is positive, colposcopy plus reflex cytology. Now let's see about CGIN. Okay, cervical glandular intraepithelial neoplasia. Now, once you find the cervical glandular pathology or your abnormality, what you are going to do? It will be complete excision. Okay, complete excision. Then you will do 2 tests of cure. The first test of cure is done at the end of 6 months. If it is negative, you have to repeat the test of cure at 12 months, that is 18 months of the total. Okay, from the excision. And if both are negative, she will be discharged to 3-year recall. Here in non-CGI, there was only test of cure at 6 months, but here first test is at 6 months and second test is after the 12 months of this. Okay, that is after the 12 months from the excision, and if both are negative, then she will be coming for the 3 years recall. Is it clear to you? Is
Yes,
it
sir.
clear? Okay, so it is not at 6 months and 12 months, it is 6 months and 18 months. Okay, Why?
Yes, sir.
Because there is going to be a lot of confusion, because you will also have the follow-up at 6 months and 12 months also subsequently. So CGIN will require two POC at 12 months apart. The first will be at 6 months, second will be at 18 months. And if it is negative, then she will come for 3-year recall. Again, here it is not a routine recall, it is a 3-year recall. So when you have an option, see to it that every places you are correct. Okay. Now the next option, you have done this test of cure at 6 months and 18 months, but the HRHPV is positive at either of the places, then you will refer to the colposcopy and reflex cytology. So you will have a long scenario, and then you see what exactly is done, whether she has got undergone the treatment of excision, and if it is a CGI, you will give two test of cure. But if the test of cure is positive either at 6 months or 18 months, she goes for the colposcopy along with the reflex cytology. Okay. Now positive cytology at any point, okay, refer to colposcopy, manage as per the findings. Okay. Now if there is a CGIN but there is an incomplete excision, generally re-excision is advised, but if the re-excision is declined, then she is for HRHPV testing every 6 months for first year, and then annually for 9 years. Okay, so here you have 6 months, 12 months, and then annual follow-up for the 9 years, and she must be reviewed in the MDT also. So this is the correct answer. If there is an incomplete excision or there is a re-excision which is declined by the patient, then HRHPV testing you have to do 6 monthly for 1 year, then annually for 9 years. So total 10 years follow-up, and she must be discussed in the MDT. So CGIN is very, very important from the examination point of view. Now let's summarize about the follow-up. So if you have a high-grade dyskaryosis or invasion or glandular neoplasia, then 2-week referral, she should be seen within 2 weeks. If there is a low-grade borderline persistent HPV positive, okay, then 18 weeks pathway, she will be seen within 6 weeks. HRHPV is negative, she will come for routine recall. So HRHPV is positive plus abnormal cytology, she goes for colposcopy immediately. HRHPV is positive and negative cytology at the end of 24 months. This also we have seen, because only HRHPV positive, negative cytology we have to repeat in 12 months. Okay, but if
12 months.
2 times we are doing, but still the cytology is negative in HRHPV, then she goes for colposcopy, but after the 12 months. Okay, when we have 2 inadequate samples, she goes for colposcopy. Okay, now post treatment, there is a CIN, HRHPV is negative, she will come for 3-year recall, not the routine recall. She comes for 3 years recall. If there is a post-treatment CIN but HRHPV is positive, she goes for colposcopy. Okay, now it is a CGIN, complete excision. You have to do 2 tests of cure at the interval of 12 months, 6 months and 18 months. Both are negative, she will come for 3 years recall. Okay, now if there is a incomplete CGIN excision and HRHPV is positive, you will have annual follow-up up to 10 years, means 6 months, 12 months, and then annual for 9 years, and she will also require MDT. Okay, so this incomplete CGIN, please remember, total 10 years of follow-up and 6 months and 12 months, not a 6 months and 18 months. Okay, here it is 6 months, 12 months, and annual for 9 years, while here it is 6 months and 18 months, both negative, 3 years recall. Is it clear difference between these two, complete and
Yes,
incomplete?
sir.
Okay,
Yes,
plus
sir.
MDT review, don't forget the MDT review option. Okay, so this is the same thing, it is what we have discussed. Suppose your HPV test, is the slide visible and clear or not very clear?
It's okay, sir. We can do it, sir.
Yeah. So you have done the HRHPV test. Now HRHPV test is negative, she goes for routine recall. But HRHPV is positive, the cytology is negative. We are not going to send for colposcopy here. We will recall for HRHPV again in 12 months time. If it is negative, the body has taken care, so she goes for routine recall. If at 12 months HRHPV is positive, then again cytology we will see. Cytology is negative, again she will not go for colposcopy. we will repeat at 12 months. So these 12 months and these 12 months, if it is positive, irrespective of the cytology, she goes for colposcopy. Okay. And if the cytology is abnormal, always she will go for referral. But at the end of 24 months, irrespective of the cytology report, whether it is negative, inadequate, or abnormal, she will definitely go for colposcopy. Okay. And at the end of 24 months, if the body has taken care of the HRHPV, then she will come for routine recall. Is it clear?
Yes, sir.